Thank you. I have no disclosures. We live in an aging society. By the year 2050, the world population over the age of 65 is expected to double, and the population over 80 will increase by over 3.5-fold. Pelvic organ prolapse symptoms peak between the ages of 70 to 79, thus we can anticipate an increasing number of elderly women who seek surgical care for prolapse. Old age, as well as elderly-specific conditions such as frailty, have been associated with perioperative complications. There are a low incidence of serious complications in this field, which presents an obstacle to the study of these events in prospective or single-institution studies, which limits our understanding. The objective of this study is to analyze the risk associated with old age and frailty in patients undergoing surgery for pelvic organ prolapse using a large national surgical database. We performed a retrospective cohort study using the American College of Surgeons National Surgical Quality Improvement Program database, or the NSQIP database. We included all patients who underwent surgery for prolapse between 2010 to 2017, and we excluded patients under the age of 45 with gynecologic malignancy and with a uterine weight over 250 grams. We gathered data including demographics, medical and surgical details, the NSQIP frailty index, and 30-day complication rates. Patients were stratified based on age. Our control group consisted of patients between the ages of 45 to 64 and is referred to as the index population. Our study groups were patients between the ages of 65 and 79, which is referred to as the elderly population, and patients 80 years and above, which is referred to as the very elderly population. The primary outcome was the composite rate of serious perioperative complications, and the secondary outcomes included rates of individual complications as well as the complication rate in frail patients. The individual complications that are part of the database are listed below, including readmission, reoperation, serious infection or sepsis, blood transfusion, bladder or bowel injury, non-home discharge, thromboembolism, pneumonia, myocardial infarction or cardiac arrest, reintubation, renal failure, stroke, and mortality. On to our results. This slide shows our demographics. We compared our elderly population and very elderly population to the index population using chi-squared, Fisher's exact, Student's t-test, and Wilcoxon rank sum. The majority of variables did differ between groups. Thus, the variables that did not differ between the elderly, very elderly versus the index group are denoted with an asterisk. In the index population, we had 27,403 patients. In the elderly, we had 20,567, and in the very elderly, we had 3,088 patients. Other than the obvious differences in age, patients in the elderly and very elderly groups did have slightly lower BMIs, a similar racial background, and lower rates of tobacco use. In regards to medical comorbidities, patients in the elderly and very elderly groups had higher rates of comorbidities such as COPD, diabetes, coagulopathy, hypertension, and had higher ASA class scores. They had higher rates of frailty. In the index population, the frailty rate was 7.2% compared to 14.5% in the elderly and 16.8% in the very elderly. In regards to surgical details, elderly and very elderly patients tended to undergo less invasive surgeries with lower rates of sacrocolpopexy, lower rates of uterosacral ligament suspension, and higher rates of colpoclesis. Midurethral sling rates were similar between groups, and hysterectomy rates decreased in the elderly and very elderly populations. In regards to our outcomes, this slide shows our complication rates. In the dark yellow highlighted column or row, you can see our primary outcome, which was the composite complication rate. In the index population, the composite complication rate was 4.5% compared to 4.7% in the elderly population, which was not a significant difference. In the very elderly population, the rate was 9.0%, which was significant with an odds ratio of 2.1 and a p-value of less than 0.001. Other notable complications that varied with age are highlighted in light yellow, including non-home discharge, which was increased in the elderly with an odds ratio of 1.9 and the very elderly with an odds ratio of 10.3. Cardiac complications with an odds ratio of 2.9 in the elderly versus 11.9 in the very elderly. Stroke with an odds ratio of 6 in the elderly versus 26.6 in the very elderly. And mortality with an odds ratio of 7.3 in the elderly and 39.9 in the very elderly. This figure shows the change in composite rate of serious complications with age. On the y-axis, you can see the rate, and the x-axis, you can see the age in years. The red dotted line shows the mean complication rate for the total population, which was 5.1%. As you can see, the composite complication rate stays low and relatively stable throughout the index population and into the elderly population. As you approach the very elderly population, in the darker blue background area, you can see a stark increase in the complication rate. This slide shows complications in frail patients only. In the index population, out of 1,974 frail patients, the composite complication rate was 5.1%. In the elderly population, out of 2,795 frail patients, the composite complication rate was 6.7%, which was not significantly different compared to the index population. In the very elderly group, out of 518 frail patients, the complication rate was 11.2%, which was significantly different compared to the index population with an odds ratio of 2.3. We performed multivariate logistic regression. After controlling for confounders, the very elderly age group of patients over the age of 80 was independently associated with the composite complication rate with an adjusted odds ratio of 2.01 and a p-value of less than 0.001. Other variables with an adjusted odds ratio greater than 2 included abdominal hysterectomy, perioperative sepsis or blood transfusion, coagulopathy, and congestive heart failure. Of note, the frailty index did carry an adjusted odds ratio of 1.4 with a p-value of 0.04. This data conveys the degree of increasing perioperative risk in the elderly patient population undergoing surgery for prolapse. The composite risk for a serious complication did increase with age. Notably, the composite risk in the elderly group of patients did not increase compared to the index group, but it was significantly elevated in the very elderly group of patients over the age of 80. Strengths include that this is a large cohort using a validated national surgical database, allowing for analysis of rare events such as mortality, as well as our consideration of frailty as a contributor to the risk. Limitations include bias inherent to retrospective design and the use of large databases, as well as our inability to address other perioperative outcomes, including pain control, cost effectiveness, return to functional status, and prolapse-specific outcomes. So in conclusion, the results of this study may be used to improve patient understanding on autonomy in the surgical decision-making process. Future studies should continue to explore optimization of the understanding of surgical treatment for pelvic organ prolapse, balancing safety, quality, and patient-centered outcomes. These are my references, and I'd like to thank my co-authors.
Thank you, Graham. A very interesting and highly relevant study regarding operations in the elderly with the demographic changes extremely important. Before I let the word go to everybody in the audience, do you think we should continue to operate on the very elderly? You didn't tell us the results, obviously, of the study, but what's your opinion?
Yeah, I think by no means would my conclusion be that we should have an age cutoff or stop operating on patients over the age of 80. I think it is more valuable in terms of our understanding and even more so patients' understanding of the risks in surgery. I think we spend a lot of time in our informed consent process in regards to our specific outcomes, prolapse-specific outcomes, and de novo urinary symptoms. But we probably spend less time in our informed consent process regarding some of these more serious complications because they're so rare in most of our patients. But I think this allows you to spend a little bit more effort and time in that consent process with the very elderly patient so that they can kind of understand that the risks, while still low, are significantly elevated.
The paper is open to discussion. Karin Glavin from Denmark.
I just wondered, did you look into what kind of anesthesia these patients had? Because in Denmark, we try to use local anesthesia whenever possible, and maybe that could reduce the cardiac complications.
Right. We did have anesthesia type as one of the variables in the study. I didn't list it in the presentation. The vast majority in the United States used general anesthesia. It did decrease slightly with age. The elderly and very elderly patients were slightly less likely to receive general anesthesia, but the majority did. And it didn't impact the outcome if they did not use general anesthesia for us.
Please.
Very nice study. You showed very nicely that we are getting a lot of complications after 80 years. But now something practical. I have an 81-year-old lady with a total prolapse, and I need to do some surgery on her because she wants it. What kind of surgery do I do? Do I do a laparoscopic sacral colpopexy? Do I do a vaginal hysterectomy plus anterior and posterior colporrhea? What kind of surgery imposes not too much stress on this lady and will give not too many complications?
Right. So one of the limitations of the study was that we did group all prolapse surgery into the same cohort. So all these patients underwent a variety of different prolapse surgeries. We did add the different types of surgeries into our logistic regression model, and none of them had highly significant impacts on the rate of composite complications. Laparoscopic approach in this cohort seemed to have a slightly lower risk of complications compared to the vaginal cohort. So laparoscopic sacral colpopexy had lower rates compared to a vaginal uterosacral ligament suspension, per se. But that's a good question. I mean, I think traditionally we think of colpocliesis, if it's appropriate in that patient, is safer, but there have been studies that show that the complication rates are similar with colpocliesis compared to some of the other operations. So I think I don't have the perfect answer for you.
But I mean, laparoscopic sacral colpopexy takes a lot of time.
Right.
Compared to all the others, and you say it gives less complications. Thank you.
Thanks.
Gil Levy from Israel. Thank you for a very interesting presentation. If you look at the literature, there were a lot of publications, not only even in other surgical disciplines, that actually show that risk is not a risk factor for surgery, and there were a couple of publications specifically in Urogyne. Can you think what will be the difference between your study and other studies that show that practically I will say the morbidity from the patients, for instance, specifically cardiac morbidity, will be a risk factor, but not specifically the age?
So you mean that age was not a risk factor in other specialties?
Exactly.
Okay. It's hard to say. I think our specialty is unique in that our patients, for the most part, are healthy. So I think the vast majority of our patients have relatively low rates of other comorbidities, and so potentially that magnifies the effect of just age as a risk factor would be one idea.
Okay. Thank you very much indeed, Graham. Thank you.
Thank you.